Okay, let's get started. I'd like to welcome everyone for the evening session. I'm Chuck Knirsch from Pfizer. I'm an infectious disease physician working in development and medical affairs. And it's my privilege actually to introduce the speakers this evening. First up is Irene Koek. She is the head of the Department of Global Health at Save the Children US. She's a recent Save the Children employee joining in 2020 during the pandemic. But has had a very accomplished career at USAID, working in a number of diseases of poverty and also with pediatrics, things like tuberculosis. She also led the development of USAID's infectious disease strategy throughout the 1990s and helped start the President's Malaria Initiative, tuberculosis, and NTDs. So without further ado, Irene, to introduce the session.
Great. Thank you so much, Chuck, and good evening, everyone. It's really my honor to welcome all of you to this session this evening, and thank you so much for coming. And I really also want to thank Pfizer, who has been working with Save the Children to organize this event, and I'm very excited to hear our panelists this evening. I also really want to thank you all. Happy Halloween for all of you, and thank you for joining us at this session as opposed to going to a Halloween party or trick-or-treating. My colleagues, Julie and Sherman, have provided some candy for all of you, which will be circulating around, so please help yourself. So tonight's session will focus on the challenges to immunization, particularly in the light of COVID, and on some of the approaches to mitigating some of those challenges. In 2019, even before COVID, we were all very, very concerned about the number of the millions of kids who were zero-dosed, who had no access to immunization, and further, the millions of kids who were under-immunized and really hadn't had the full regimen of immunizations. That was even before COVID. And certainly in the early days of COVID, we really saw sort of some real disruptions to the delivery of immunizations, either through routine vaccination programs or through campaigns or other outreach events. Fortunately, in many cases, we were able to come back from some of that, but that still has left us millions and millions of kids who are not accessing vaccines in the way they should, and millions of adolescents and others who haven't. And of course, we've seen the same impact on the rollout of COVID vaccine in many countries around the world, and the discrepancies in who's actually been able to access the COVID vaccine and use it, even despite the supply issues being addressed. So at the core of all of these issues is, of course, the inequity, which is, of course, does not exist in a vacuum, but it's the result of varied and often very complex, entrenched social, political, economic forces and discrimination. Addressing this really does require an analysis, intentionality, and inclusion of those who are affected, and often very different approaches. As we heard at the opening yesterday, and the theme for this year's ASTMH conference is, of course, global health, is global health and human rights. And as we heard yesterday, it's a really terrific presentation about the impact, as we see, of what that inequity and the political decisions can make on really improving people's health and giving people access to the health services they need. And as Professor Barreto said, poverty and social inequality throughout history have always manifested as poor health and health inequities. So global crises, including COVID and the new and ongoing conflict, and of course climate change, have exacerbated health inequities and continue to threaten the remarkable progress we've really seen for reducing child mortality over the last few decades. And addressing these issues of inequity are fundamental to really getting to full immunization coverage. Addressing inequity is, of course, fundamental to Save the Children's work, and it's very core to our mission. We are very committed to making sure children survive, thrive, and are educated and protected. And we work both in emergency settings and also with communities around the world in low and middle income countries, particularly those who are not reached by the system or suffer from discrimination or other issues. Our immunization programs have really focused on partnering with ministries of health, with communities and civil society to reach those zero-dosed and under-immunized children. and ensure equitable access to immunization so that no one, no child, no adult, no adolescent is left behind. We advocate and we also partner with governments, donors, civil society, and communities, and partners such as Pfizer, as well as Gavi, UNICEF, WHO, et cetera, and of course, other technical and humanitarian partners. Core to our work in immunization is active inclusion, engaging communities, pushing for visibility on those who are left out, and trying out innovative approaches to overcome barriers and those challenges in partnership with all of those I've mentioned before, to trying to bring to scale the use of and access to immunization services. This evening, you'll hear from some of my colleagues who have been doing just that and who have been finding ways to overcome some of the challenges not only of COVID, but of addressing these inequities. So let me not delay any further and let you hear from all of them. Thank you again for joining us this evening, and I look forward to our presentations. Back to you, Chuck.
So our keynote speaker tonight is Dr. Siddique, who is the head of coverage and equity implementation unit at UNICEF. Dr. Siddique has had a really very illustrious career, nearly 2 decades at UNICEF, and his accomplishments and the programs that he's overseen are really quite remarkable. Spent quite a bit of time in Nigeria working on polio, also prior to that also working in India and Bangladesh. And of note, he was a pioneer really in formulating village health nutrition days, which is something that's been critical to that. Also just the elimination of polio in Bangladesh in a 2-year time, so that really bringing the full weight and of UNICEF to eliminate this disease. Dr. Siddique, please come and for the keynotes.
Respected Chair, Chuck, and distinguished audience. I'm going to discuss some of the impact of the pandemic on the immunization service disruptions and what we are doing with UNICEF and along with the partners globally. This is the slide perhaps you have seen in the past. This data is coming from the WHO and UNICEF joint estimate, which was estimated in 2021. And you see that 25 million children were un or under immunized. And that is 2 million more than 2020 and 6 million more than 2019. Now, this pandemic actually represents the worst continued decline coverage that is reported in 30 years. And that is not only the pandemic, the coverage was plateaued for 12 years. So, this is a synergistic effect, pandemic and, plateaued coverage for a while. And as mentioned about the 0 dose, these communities, they face multiple deprivations and also, the other adversities such as conflict, food crisis, measles outbreak, they're all, interrelated. And just to mention the 0 dose, and 0 dose is the children who never received any vaccine after birth. So those who has a potential to receive vaccine. And if you look at the slide on the top, you see DPT1 coverage that is 81% in 2021, which was. And then the 28 also, it was 81%. So we are back to the square, what we achieved in last couple of years. And the bottom of the slide and the bar chart, if you look at 2019 zero-dose status was 13.3 million, and the dropout is 5.9 million. So zero dose is actually measured against DPT1. So indicator is DPT1. So you see the 13.3 million DPT1 is missed, and then the others are, who did not receive up to the DPT3. But in 2020, you see the number has increased to 16.5 million, and the total missed children reached to 22.9 million. And 2021, zero dose increased to 18 million, and the dropout 6.8 million. So 25 million children missed out. So this is a huge number that we need to consider that the pandemic caused. And if you look at the UNICEF region across, UNICEF work in 190 countries. And these countries are divided into several regions. The East Asia and Pacific region, European and Central Asia, East and South African region, Latin America and Caribbean, Mediterranean and North Africa, South Asia, and West Africa and Central Africa. So in all the region, the decline is quite substantial. In Pacific region, the 94% 2019 coverage has reduced to 85%, so 9% change. In ISARO, that East Africa and it's minus 6% coverage decline. LACRO, Latin America, and the South America is minus 4%. Even the South Asia, India, and the region overall is minus 4%. So there is no evidence that we gain any coverage in last 1 year. So in 2021, if you look at the 20 countries accounted for 72% of the total 18 million zero-dose children globally. So it's India 2.7 million, Nigeria 2.2 million, Indonesia 1.1 million, Ethiopia 1.1 million, Philippines, followed by DR Congo, Brazil, Pakistan, Angola, and Myanmar is up to 500,000. And followed by other 20 countries, that is Tanzania, Mozambique, Afghanistan, Somalia, Mexico, Madagascar, Cameroon, DPR, Korea, and Chad, and Vietnam. And while the number of zero dose is very high in India, but if you look at on the bottom, the coverage, DPT1 coverage in India is 80 to 89%. While in Nigeria, it is 7 to 79%. So there is because of the high birth cohort in India, so you have you see that naturally there are a higher number of zero doses, but their DPT1 coverage is not that low compared to the other countries. The worst hit is the HPV vaccination. Before pandemic, the HPV coverage was steadily increasing. And if you see that due to the pandemic, the coverage fell by 15%. And we have seen in some of the countries who are doing very well in the HPV coverage, and we found that the schools are closed and the girls are not coming to school, and there is no community-based outreach to reach out those adolescent girls. So it apparently that a generation is lost for vaccination. So this is an urgent need for vaccination, and there is a call for HPV relaunch, which is under discussion. So and we see that as a result, the number of girls who never received a first dose of HPV has increased by 3.5 million since 2019. So in all these, if you think that there is no measure undertaken, then what will happen? And we see that in our region, like in East Asia and Pacific, if you are not taking any measure, if you want to increase, if you want to reach the coverage up to 2019 level, it will take 2041. Similar with the East Africa region, it will take 2040. In LACRO, Latin America and South America, it will take 2038. In Mediterranean and North Africa, it will take 2028. In South Asia, it will take 2025. In Europe and Central America, it will take 2022, and West Africa and Central Africa, it will take another. We have some kind of, acceleration is taking place, which shows that they reach to this level of 2019 coverage, according to the estimate. If you look by country, year to reach to pre-pandemic level by countries, 56 country, somehow they were able to, regain or they were able to catch up and able to avert the backslide. But a couple of countries are not able to do it, and 20 countries, which is listed here, such as Argentina, Bahama, Barbados, Djibouti, Dominica, Gambia, Indonesia, Honduras, Jordan, Kyrgyzstan, Lebanon, St. Lucia, Republic of North Macedonia, Myanmar, Mozambique, Nicaragua, Philippines, Papua New Guinea, Democratic Republics of Korea, Paraguay, and Rwanda. They will take 20 years if there is no measure taken. So, and where these zero dose were living, there are three settings: this remote rural, urban poor, and the conflict fragile. And the gender is overarching the issues related to the gender, which also undermining coverage. So in remote rural, which we know traditionally the marginal cost and for reaching out to the children and outreach is expensive, and recruiting, retaining, and motivating health workers, and that is impacted by the context and the limited situations, distance, and have other socioeconomic situations is not allowing to reach those children who are in the rural remote. Urban poor is even with the urbanization, and peri-urban vaccination is also a big issue. The social exclusion, the issues of the illegal settlements, and the poor design of the immunization service, and sometimes they're inaccessible, and of course in some areas the insecurity and multiple stakeholders and not able to coordinate each other, and then they're not able to reach those children. Conflict and fragile, the overall, we see that the conflict and fragile countries having most number of zero-dose children, and because of the damaged infrastructure and the migration of the skilled health workers, decreased access, and other large-scale population displacement. So all these factored in poor coverage in conflict and fragile settings. And gender in general, the issues around coverage and immunization coverage is interlinked, and in considering the lower status of the communities and the limited capacity to act, physical and time barriers to accessing immunization services, and fathers' involvement in vaccination is also a big issue. So all these impacting higher number of missed children in these three settings. So if you bring the top 20 country map for zero dose or missed community, and then if you bring the map for other issues like food crisis, conflict, and institutional and social fragility, you will find that there is a synchronization. So in this map, perhaps except India, all other countries, those who are in the top 20 country for zero dose are having one or other issues like food crisis or conflict or measles outbreak. So, countries are facing the overlapping crisis, and actually it creates more issues for immunization coverage, and coverage is declined and deteriorated, and there is no sign for improvement. So what are we going to do in this situation? Globally, we work with the Immunization Agenda 2030 along with our partners, with Gavi, with WHO, and other donor community and agencies like Save the Children. So the first priority is catching up on children who have missed routine immunization, and those countries recover for backsliding that has occurred since 2020. So the catching up campaign is very, very critical. Countries like India, Nepal and Bangladesh, and showed a lot of promise, increasing the age limit, and also that allowed more number of children who the cohort has missed the vaccination. And restoring the vaccination services, countries and they restart the essential services, including routine immunization. So that is combined in the primary healthcare services, and reinstitute the disruption along with the vaccination session. In many countries, COVID vaccination given the topmost priority, and we see that how we can combine and just integrate this and restoring the services. And the third stage is acceleration. So the acceleration is that this beyond 2019 is beyond the restoration to speed up the vaccination process and sustain the recovered coverage, and then expand the coverage and for the missed children, and create the safety net so that children are covered. So there is a global plan that is talking about how to restore the vaccination, how to accelerate the immunization. But then how we work? We work through the country plan. So at the moment, top 10 countries, those who has highest number of zero dose, are prioritized. And there is a global guideline developed and then has been shared with these countries, and then they rapidly to improve their coverage. And it talks about using the unique data for advocacy, and to some extent the political leadership is fully aware of the COVID vaccination, but they are not aware about the childhood vaccination because they share issues of prioritization. So we're trying to use this data for advocacy, and there is a deep dive going on at this stage with these 10 countries and identified and the locations. So we identify some of the areas where these zero dose are mostly predominant, and bottleneck analysis has been completed in some of the countries. And interventions are already launched in some countries, for example, in Brazil, DRC, Nigeria, Ethiopia, and Angola. And we are working with India, Pakistan, Philippines, Myanmar, and two other countries, DRC. So the 10 countries are more or less they are on track for the deep dive exercise, and the process of restoration coverage the pre-pandemic level is underway. So there is a $1 billion plan is underway for 20 countries for resource mobilization, and then leadership meeting is planned in January, which UNICEF is launching with the State of World Children, which will be launched in February. So it will be combined with this leadership meeting and the SOWC meeting. So our priority, leading this activity at the country level, engage with the high-level dialogues and convening and co-convening partnership meetings, and advocate for to take it in an emergency mode, and then act, basis the deep dive and monitor on the progress. So in short and summary is that what is our strategic approach is a two-prong approach, that reducing the number of zero-dose children through intensified effort and catch-up campaigns, and strengthening primary healthcare services and systems, and investing in primary healthcare and specific support to essential immunization service. So if you look at this slide, you see that our target is by 2025 to reach the coverage level to at least 86 to 85 to 86%, so that to make sure that we are at par at the 2019 average. And in the long run, what we see that out of these zero-dose children, 14.6 million children that resides in 20 countries, so that we can reach to them with the improved coverage and with the accelerated plan. And to respond that, we must catch up those missed children, and that is our target is by 2025 at the pre-pandemic level, and 2030 that we reach at least 50% of the zero-dose children. So that is the global plan, and that is what I thought to share with you here. Thank you very much for your patience hearing.
Thank you for that talk. Just to see the very big picture that UNICEF has to catch up. So I think what we're going to do now is go to two teams that are really at the front lines of trying to make these things happen. And I'll invite both our speakers from Kenya to come up now to go over the door-to-door strategy. So first we'll have Dr. Linda Masiko. She's the Health Technical Advisor for Save the Children in Kenya, and that will be followed by Dr. Azma Ali Awad, who's the Sub-County Medical Officer of Health, Kibalangata Sub-County, Nairobi. So Dr. Masiko, maybe both come up just because. Let's see. You know where to find the slides.
Yeah. So good evening. I'll be taking you through the first part of this presentation, which is the door-to-door immunization strategy in Kenya. The outline of this presentation, I'll take you through the COVID-19 context in Kenya, the impact of COVID-19 on child immunization, the door-to-door strategy, which will detail on the methodology and the achievements, and then the challenges and the lessons learned. So when you look at the COVID-19 context in Kenya in 2020, the first case of the coronavirus was confirmed on the 13th of March 2020. We obviously know that this became a global pandemic that affected the whole world. And in Kenya, our health system is under-resourced and not well-equipped to be able to handle such a wide-scale medical emergency. And with that regard, the Ministry of Health was able to put restrictions to be able to curb the transmission of the virus. And they put restrictions in terms of lockdowns to restrict movements and curfews, reduction of crowding at the hospitals, and a ban on all public gathering, including schools closure and close of places of worship. So in light of this saw a reduction in terms of access to essential health services. We saw an increase in community reluctance for people to be able to seek health services from the facilities because, you know, at that particular time, WHO issued some guidance in terms of zoning of high-risk areas, and one of the areas that was considered high-risk was hospitals. So this saw a reduction in health-seeking services to the facility level, and with that led to a disruption in terms of routine immunization. So to be able to respond to that, the Ministry of Health Kenya was able now to monitor the status of essential health services by analyzing key performance indicators. The ministry selected 30 health indicators that they were able to monitor the performance of these indicators so that they can be able to come up with recommendations for the country for us to be able to maintain and to sustain access and utilization to essential health services. So one of the performance indicators that was being monitored was the outpatient department visits for children under 5. So when you look at that, you can be able to see that when we got the first COVID-19 case identified and when the analysis of the performance indicators began, you can see there's a sharp dip of the number of visits for children under 5. You can see there's a sharp dip between March and then up to April, and then it started rising slightly in 2020. So definitely with that decline in the number of OPD visits, this had a ripple effect and it was able to affect the routine immunization services. So as a country, the ministry was able to develop essential guidelines to ensure continuity of health services. And Save the Children, we came together with the Ministry of Health, Nairobi County, together with our local partners to be able to develop a response to be able to address the issues about disruption in the routine immunization services. And that was what gave birth to the door-to-door immunization strategy, which is a strategy that is used to be able to locate, to trace, and to vaccinate our missed children. So when you look at that, those are healthcare workers. You can see they have the vaccine carrier together with our community health volunteers. They're actually at the community, at the household level, where they're going to the different households to be able to vaccinate the missed children. So at this particular juncture, I just want to share a short clip with you to be able to see the door-to-door immunization strategy.
One of the approaches being used in the Pfizer...
Sorry.
In Kibra, Nairobi, it is now common for health workers to move from... One of the approaches being used in the Pfizer-funded project that was born in 2020 is through community health workers. In Kibra, Nairobi, it is now common for health workers to move from door to door, sensitizing families on the need to have their children vaccinated.
Save the Children imetuweza kutupea elimu, imetusomesha sisi kama CHV, tukajua kazi yetu zaidi, tukajua mchanjo from BCG mpaka measles huko. Tunashughulika na hawa watoto under 5s, tunashughulika na wamama wajawazito, tunafanya referrals kwa tukipata tatizo kwa kijiji. Pia tunashughulika na magonjwa yote ama defaulters pia tukipata kwa kijiji tuna refer hospitali.
Mtu kama Grace, kama mimi amenisaidia sana. Ningepuuza tu na mtoto akae tu hivyo. Sasa tumesaidika, nimeelezewa venye naweza endelea na kumleta clinic. Amedungwa hii sindano ya measles. Sasa nimepangwa vizuri venye nikikuja after 1 month watakuwa wananisaidia.
Okay. I'll now hand over to the second part of this session to be taken through with my colleague, Dr. Asma, to take us through the implementation of this strategy. Thank you.
So I'll take you through how it's done. So with the door-to-door strategy, what we started first, we identify and list the defaulter or the missed children. And after that, once we list them, we actually check where they're coming from or which village we're having the highest number of children who are missed out. And from there, we look at the facility that is within that village as a link facility, and we link each and every child who is missed in that facility. We call in our community team, so we have community mobilization whereby the community team comes on the ground, tell the community that we are coming in to do vaccination for the missed children. And we have now facility level preparation where we have our nurses, the vaccinators, and the CHVs themselves, the community health, CHVs, community health volunteers, who will be ready, prepare their vaccines, the carrier and all that, and then go on the ground. Most of the time, we'll pick to go in over the weekends where we are sure we'll find the children there and we find the parent or the guidance who will be on the ground. And after we have the door-to-door strategy, at the end of the day, we'll sit in and have a feedback meeting to see what is there. Now, what we noted on a monthly basis, we'll have high number of clients reached. Like for the first time when we started in May, we were able to reach about 677 clients in the community. And all through, we were able to capture the children that we have missed, and also we realized we were able to do more than what we had targeted to do. So we started as to have just vaccinating the defaulters or the children that were missed. But we realized when you go on the ground, there are a lot of more. Like, for instance, the closure of school, meaning the HPV vaccine was missed out. So we were able to vaccinate our girls against the HPV virus. We were able to treat and also offer maternity services to pregnant women. There was a discouragement for any pregnant mother not to access facility unless they need because of the pandemic. So with that, we were able to offer any antenatal services on the ground, immunize our children, treat any minor illness, and also give supplementation, deworming the children as well. When you're looking at what were targets, so when we do our list, for instance, in May, in our list of defaulter, we had 41 children who were missed out in regards to vaccines. But when we go on the ground, we are able to actually get more than. So we have the defaulter list reading 41, but the reached children who are on the ground were about 44. And we had these numbers increased throughout the months. So what are the supporters? One of the things that actually was able to make this a success with the door-to-door strategy was the fact that we had the community mobilization happening. So the community goes down and mobilize and have all the children being in one place, which enabled that acceptance. So by the time we come into the community to vaccinate, there was no resistance by the community team, and they were able to actually accept knowing we were coming to vaccinate. And the inclusion of the community strategy team. So we had our community focal person, the health assistant from the community, and the community health volunteers as part of the team. We didn't go in just as healthcare workers. We had the whole community team as part of the strategy, and it was very easy for it to be accepted on the ground. The achievement, we were able to actually incorporate the door-to-door strategy at a national level as a guideline. For instance, currently we're also using the same strategy to increase our uptake for COVID vaccine. So, and one step forward, the National Vaccine Immunization Program review the Reach Every District or Reach Every Child guidelines so that they're incorporating the door-to-door strategy to enable each and every child is reached and immunized against childhood diseases. The adoption of this strategy was also put at facility level microplanning. So when we have our facility microplanning, they actually incorporate the door-to-door strategy as part of one of the strategies that they will use to ensure they are vaccinated, each and every child within that village where the facility is. Some of the challenges that we had is staff constraint. Apart from fatigue and burnout, remember we're doing this over the weekends or public holidays. So we needed to have our healthcare workers come on the days that they're not supposed to work to go on the ground. Kibra sub-county was actually one of the sub-counties with the highest caseload in regards to COVID-19. So there was a bit of resistance from the healthcare workers and reluctance to go on the ground because of fear of COVID. So that's led to a bit of constraint in having the staffing to go on the ground. And there's budget limitation as well. Remember, when you call in the healthcare workers out of their working hours, then it will cost transport and all that. So there was a bit of budget limitation. That was a bit of a challenge for us. But one of the things that we learned, involving the community team, all the community team, all the way from the community health focal person, the community health volunteer themselves, the village elders and all that, made it a success. And it was easily acceptable. And there was coordination and collaboration with to promote the sustainability and adoption of the door-to-door strategy, whereby we had pooling of resources, working with the partners, working with the national government and the county government, enabled this to be a success for us. Thank you very much.
Thank you for those talks. Just remarkable work under very, extenuating circumstances. So we're going to change geographies now, and I invite Dr. Rana and Dr. Haq to come up to the stage now to do the next presentation regarding catch-up after COVID-19 disruptions in Bangladesh. So Dr. Rana is the project manager for tackling the childhood pneumonia project for Save the Children in Bangladesh. And Dr. Shamsul Haq is the line director in the Directorate General of Health Services in the Ministry of Health and Family Welfare in Bangladesh. So, gentlemen, please come up. Just make sure. Good.
Bismillah ar-Rahman ar-Rahim. Thank you, respected Chair and distinguished guest. Bangladesh, which is situated in the Southeast Asian part of the world, region of the world, and got independence in the year of 1971 under the leadership of Bangabandhu Sheikh Mujibur Rahman. The total area of Bangladesh is about 148,000 square kilometer, having 8 divisions, 64 districts, and 495 upazila or sub-districts. And in the geographical distribution, we have 3% sub-districts are hard-to-reach areas. Total population is 165 million, and growth rate is 1.08%. Annual birth cohort 3.4 million. Child immunization is one of the largest program which is run by EPI, that is Expanded Program of Immunization under DGHS. Total number of estimated children, that is already I have told, that 3.4 million, and women 15 to 49 years, that is 48.8 million. Yearly immunization sessions held, that is planned in 2020, was 1.46 million. These immunization sessions has been planned early in the every year by micro-planning. And total number of cold chain points 732. Total number of vaccinators now more than 15,000. During the COVID situation, like other countries of the world, on 8th March 2020, Bangladesh reported the first 3 confirmed COVID case. And throughout the COVID journey, we have lost more than 29,000 people. And during the year of before COVID situations, according to Coverage Evaluation Survey 2019, our EPI coverage in BCG was 99.7%. And Penta 3, that is 93.3%, MR or MCV 1, 88.6%. Fully vaccinated child in the Coverage Evaluation Survey, it is 83.9%. And we have collected all the data through our DHIS2, that is our monitoring system. And in this slide, I have shown you that the situation of different antigens in the early of 2020, that is the January 20, and the month of March 20, the sharp decline of the vaccination, all the vaccine antigens. And at that time, we have a comparative analysis that all divisions had similar trends in routine child immunization throughout the pandemic. Sessions not held 20%, average 25% in the whole country. And Penta 3 coverage declined about 45% in the COVID situation. Urban affected more than rural. Penta 3 coverage, April 2020, urban is 7% and rural is 50%. We know the challenges because at that time there is more challenge in the physical supervision and monitoring, and fear of getting COVID-19 among the health workers and the community people. And most of the health workers were infected by COVID. Compromised access and utilization. Orientation of new mid-level managers, it was a great challenge at that time for us. And health worker fatigue. And we have, there is a great challenge, that is COVID-19 patient management in the health facilities led to low conduction of fixed sessions. Fear in the community led to low conduction of outreach sessions because our most of the health workers, that is health assistants, they are involved in collecting the samples and also to find out the patients. And immunization staff were repurposed to COVID-19 mitigation activities. And another, like other countries, we have started lockdowns and shutdowns. And previous slide you have seen that 3 times we have a first wave, second wave, and third wave. All the time, they more or less there is a disruption in the COVID vaccination. But in the month of November, we have, though in the COVID situation, we have a challenge to perform a nationwide MR campaign. That's why there was a fall. But in the third wave, we have compromised it, and the situation was mitigated. Actions taken to revitalize the service. We have developed guidelines to conduct routine immunization during the pandemic, and IPC training to all vaccinators through not in the physical training, but virtual training started. And resource mobilization, it was a great challenge, but we have tried our best. And uninterrupted supply chain, though it was a lockdown and curfew at that time, but our government was too much passionate for vaccine. So supply chain re-established, and it was uninterrupted. Reinforced monitoring and supervision virtually, because we have a strong monitoring system by DHIS2, so we can contact with our sub-district level and even in the health workers that to address their present condition. And social and behavioral change communication has been established. And here is a paper, presentation that this is the guideline to conduct the COVID situation. We have developed this and circulate to all the vaccinators. And what we have learned in this situation, that strong political commitment, that you know that our Prime Minister is very much concerned about the vaccination program with multi-sectoral coordination and robust system. Also the development and implementation of futuristic policy making and capacity building and thoughtful resource mobilization. And Bangladesh regained the vaccination, routine immunization program within the shortest period of time. Thank you. Now I am requesting my co-partner, that is Dr. Sohail Rana, to present his part.
Thank you, sir. Thank you, Honorable Chairperson and respected audience. So you actually observing or watching the national features. Now actually I am sharing activities that actually done by the Save the Children with the collaboration of the Ministry of Health in a small area, in a district approach. So Save the Children is implementing one pneumonia program, that is tackling pneumonia in Bangladesh in 6 sub-districts of Borishal districts. And this district is actually a riverine country, and this 6 sub-districts were selected based on geographical challenge as well as the low coverage. So what is actually, it is a pneumonia treatment or prevention programs. So you know that if you want to combat the pneumonia, so you should treat. So that's why a strategy is early diagnosis and quality access of services, and ensure to prevent the child, that is vaccination, and to protect the child, actually using increasing the coordination as well as the increase the investment in the pneumonia, especially in the Borishal region. So what actually we observed, you see the national scenario. Now actually I am sharing the 6 sub-district scenario. You see, when the first case was identified, there is a sharp fall in the session conduction. So in the, especially in the April and May. And later on, when the everything is set up, then this immunization actually will increasing by month of June. And you see that in the December already, as I mentioned, there is a national-wide measles and rubella campaign. So government planned that session will be reduced in the December. So that's why this is not actually the underachievement. It is actually the planned, actually because due to this MR situation. And what actually we see that in the second wave and third wave, there is no such decline in the session held up, because they learned actually how they will manage things in this emergency situation. Same as we are working there as a pneumonia program. So PCV, that is pneumonia conjugate vaccine, is our indicator. So we see in the April and May, there is a sharp fall in the PCV immunization. But later on, actually, it was cast up. You see that upward trends. You see the dotted line, it is average target. But after the COVID, it is always go upwards. So that indicates actually the what strategy Ministry of Health and Family Welfare taken that was very effective. So what actually we did at the local level, we provide some technical assistance and managerial support to the local Ministry of Health authorities and facilitate the vaccine dropout, especially in the zero and especially in the hard to reach area through different campaign. And already you know that government take some initiatives like infection prevention training and as well as providing the PPE, that is personal protective equipment, so like gloves, mask, hand sanitizer like this. And Save the Children have some community volunteer that alignment is the government program, another that is community clinic program, you know that. So we involve that volunteer to mobilize the community to actually take that vaccine. So I am just showing one of the snap actually how vaccine actually reached from cold room to the beneficiary, especially in the hard to reach area. So
স্বাস্থ্য সহকারী উপজেলা স্বাস্থ্য কমপ্লেক্স মেহেন্দিগঞ্জ বরিশাল। আমরা 15 থেকে 49 বছরের মাদেরকে গর্ভবতী মা সহ আমরা টিটি টিকা ধনুষ্টঙ্কারের জন্য আমরা এটা দিয়ে আসছি। এখন মহিলাদেরকে আমরা দুটি রোগের টিকা দিচ্ছি, ধনুষ্টঙ্কার এবং ডিপথেরিয়া, দুটি রোগের টিকা দিচ্ছি এবং শিশুদেরকে 10টি রোগের টিকা দিয়ে আসছি। এই বিশেষ প্রোগ্রামের মাধ্যমে আমাদের এই দুর্গম চরাঞ্চলে যে টিকাগুলো দিচ্ছি শিশুদেরকে এবং মাদেরকে, এর মাধ্যমে আমাদের শিশুরা এবং মারা এই 10টি রোগের হাত থেকে মুক্ত থাকতে পারতেছে। বিশেষভাবে আমি ধন্যবাদ জানাচ্ছি সেভ দ্য চিলড্রেন যারা আমাদেরকে সহায়তা দিচ্ছে আজকের এই টিকার জন্য।
সেভ দ্য চিলড্রেন সরকার আমার বাচ্চাকে টিকা দিছে, আমি খুব খুশি আছি।
আমি 8.5 মাসের গর্ভবতী, আমি টিকা দিতে আইছি।
আমি মোহাম্মদ আমির হোসেন, মেহেন্দিগঞ্জ স্বাস্থ্য কমপ্লেক্স নিয়মিত ভোটার। আমার অনেক কষ্ট করেই যাইতে হয় সব ক্ষেত্রে, এই জন্য আমি আসলে বাচ্চাদের ঠিক মতন টিকা দেওয়া হয়, সঠিকভাবে বাচ্চা এবং গর্ভবতী মহিলারা ঠিক করে টিকাটা পায়, এই জন্য সেভ দ্য চিলড্রেন আর সরকারকে অনেক ধন্যবাদ।
Okay, so what actually we learned, this is our journey in the last 2 years. We see that there is actually restoring the EPI and other service, consulting service after June. It is actually due to the commitment of governments. And we thought that sometimes need a specific and context alternative approach is working, like mobile immunization site like crash programs and targeted household visit. Already it is proven that if the health worker visited the targeted house, then actually it is effective to come that back to the children to the immunization site. And we actually find that support to the strengthening the support to the MOH, that is Ministry of Health, is a really critical, especially to mitigate the challenge, continue the critical health services during and after the any disasters like COVID. So that's actually from all my presentation. Thank you for patience hearing.
Thank you for showing us the situation in a very different part of the world. I think those videos, both from Nairobi and from Bangladesh, really give us a sense of the work that you're doing there. So thank you for that. So we will conclude the evening with two speakers from the IVAC group at Johns Hopkins. And the first is Dr. Chizoda Winode, who is both a physician and a doctorate in public health, has been working extensively in Africa and Asia, and particularly around the introduction of new vaccines like the COVID-19 vaccine in Nigeria, Tanzania, and Madagascar. She's currently the director of immunization for the USA-funded Momentum Country and Global Leadership Project, which aims to support countries to raise the coverage and equity of proven public health interventions. So, Dr. Winode, over to you, please. Presentations are there.
This one. Thank you very much. Okay. Good evening, everyone. Thank you for staying back this late. Thank you to the Save the Children team for inviting us to this symposium. I want to talk about a systematic literature review that we're doing to really describe the disruption of routine immunization as a result of COVID. And it's really interesting to have heard the presentations that came before me, and it really cements what we are finding from the literature. So this is the outline of my presentation. And I also thank you, Dr. Siddique, for doing my job for me. I'm not going to dwell on this slide because you've already presented it to show that COVID vaccine has really devastated health and health systems as well as economic systems around the world. And so what we wanted to do with this literature review is we've seen the data, we've seen the declines in immunization coverage, but we wanted to describe from a systems point of view what was really going on with the disruption. And so we wanted to look at the nature and the extent of the disruption and what's in the published literature, as well as the promising interventions that have been rolled out by immunization systems to address the disruptions, and then synthesize lessons learned for restoring immunization for now, and then also to improve pandemic preparedness. What we did was to use a framework that was derived from the WHO health systems building block. So we wanted to look at what is described around disruption to leadership, to vaccine supply, service delivery, demand generation, data and accountability, human and financial resources. So what is in the literature and how did the health systems respond? So our methods are the standard systematic literature review methods. We looked at peer-reviewed publications in 7 databases, and we built a search strategy around three different concepts: COVID-19, health systems, immunization, surveillance, and we limited our search to low and middle income countries. We had pre-existing inclusion and exclusion criteria that we used, and in terms of our synthesis, we did a narrative synthesis instead of the usual summative summaries because of the heterogeneity in the outcomes that were reported for the different studies. So in terms of our results, here is our Prisma diagram, as it's called. What you see here is that we ended up with 31 studies from 5 WHO regions. We started with our initial search yielded like almost 12,000 papers, but by the time we'd gone through the title and abstract screening and applying our inclusion and exclusion criteria, we ended up with 31 studies. And we limited our search to studies that were published in 2020 as well as 2021. And in terms of the geographic focus, you can see here that, like I said, all but one WHO region was represented. The one that was not represented is the West Pacific region. The studies were mostly focused on children. So 24 out of the 31 studies were focused on childhood vaccination, and then the rest were on adults and adolescents. So in terms of the study design, there were basically 4 types of study designs from what we could see. There were studies that compared coverage before pandemic and after the pandemic. There were also time series analysis of routine immunization data. There were also studies that interviewed stakeholders like parents, healthcare workers, workers in the pharmaceutical industry, as well as program evaluation. And the data collected ranged from January 2017 for the pre-pandemic period to the latest data in the post-pandemic period was January 2021. But more than half of the studies, their end-line data stopped in the second quarter of 2020. So the implication is that most of the studies here really focused on the impact in the immediate pandemic period, so after the declaration. And then another thing, like I mentioned earlier, is that there were 41 different outcomes that were reported in this study. So synthesizing them numerically was quite difficult. So what we did was just look at the narrative summaries. So what did we find? In the first few months after the pandemic hit, service delivery and service uptake dropped precipitously. We could hear also from the report from Bangladesh and as well as in Kenya. There were temporary vaccination clinic closures. So reports from Uganda and Pakistan supported that. There was also suspension of outreach and fixed services. There were reports from Pakistan on that. And campaigns were also suspended. A multi-country analysis from Burkina Faso, Gambia, and Tanzania reported up to a 95% drop in new patients attending outpatient clinic. And then studies from Pakistan also reported 53% drop in daily immunization visits from children. Similarly, we saw a study from Pakistan that showed that about a third of the health facilities that were open during the pandemic had no patient flow at all. So it was a combination of the services not being offered, either closed or suspended or reduced, and clients not coming. So the reasons for the decline in uptake and demand of immunization services were varied. From the caregiver perspective, it was really a fear of COVID, like we'd heard in Bangladesh, and it was worsened by rumors and misinformation. Then lockdowns, of course, affected people's movements and ability to access care. And there was also difficulty finding transportation. In some studies, they reported higher commuting costs as a result of the movement restrictions. And then the sometimes the fear of COVID was accentuated when the COVID services were co-located with immunization services. And then due to the limited services, there were long lines, and so this discouraged parents from accessing care. Health workers also faced challenges with getting to work as well as doing the work. They also were the front lines, and they faced the fears of COVID exposure. Like was mentioned also, task shifting diverted health workers, immunization workers into COVID response, and so that led to staff shortage, which may also explain some of the long lines that clients complained about. They faced transportation difficulties, and in the early part of the pandemic, there were lack of personal protective equipment, so that also limited their ability to provide services. And this all therefore ended up in reduction of vaccination coverage, as well as other ancillary vaccination activities like surveillance activities. So we found that in almost all the studies that we looked at where they reported vaccination coverage, be it measles, DPT, BCG, OPV, there were declines in coverage comparing before and after the pandemic. A study in Pakistan reported, for example, that the measles vaccine declined between 22% to 49% when comparing the post-pandemic period to 2019. And as mentioned in Bangladesh as well, this decline was actually worse in the first 2-3 months after the pandemic was declared. So in this South African study, what we saw is they described like a 30% reduction in measles coverage amongst infants in April 2020. But by May, that reduction in coverage was attenuated to about 5 to 10%. And by June, coverage had returned to normal levels. So it appeared that there was some recovery that happened a couple of months after the pandemic was announced. And then we also find that in terms of surveillance activities, there was a disruption of surveillance activities and a paradoxical decline or expected decline in the identification of AFP cases, that's acute flaccid paralysis. So this is one of the indicators that we used to track for polio. So this was reported by a study by WHO where they reported 33% reduction in AFP cases. And the reason for that was really a delay in stool sample collection and receipt of stool samples. So this really harkens to the transportation difficulties that were imposed by the lockdowns. And then another multi-country analysis noted that there were interruptions in AFP cases due to delays in shipping and testing of stools. So logistic challenges also affected surveillance activities. And then finally, we looked at interventions that were used to address these disruptions. And we found just 5 papers that reported this. But obviously, even from this symposium here, we can tell that there is a lot of experience out there that's not captured in the literature. And so in terms of service delivery, you find that there were interventions using mass vaccination to address the disruption. There were home vaccination for the elderly. There were use of fixed mobile services. There were also drive-through strategies that were used in Brazil. This is really to reduce exposure to the service delivery settings. And then there were crowd control measures that were put in place, such as using registration and using cards and limiting the number of parents that come with children for vaccination. In terms of human resources, there were capacity building, Zoom and use of virtual training sessions was really adopted widely. And then there were revisions of standard operating procedures to ensure that the services were delivered in a safe and effective way. There were demand generation innovations, particularly partnerships with different types of stakeholders that ordinarily were not involved in immunization. And then there were use of nursing students to volunteer to support service delivery, and then partnership with school authorities to disseminate information about vaccination. So these were some of the interventions that were put in place. So what we then our conclusion really looking at the data is that, first of all, we see from the literature that these reports confirm the studies or the UNICEF estimates that show that COVID really disrupted immunization services and impacted negatively on vaccination outcomes. And these were largely due to the lockdowns, the movement restriction, transportation difficulties, the task shifting, the lack of PPEs for healthcare workers, and then as well as just drop in demand by parents. Then we also note from our discussion that catch-up and recovery is really important. We know that recovery has started, as we can see from the data, but it's not complete yet, as we can also see from the UNIC data. So we really need to step up efforts around catch-up campaigns and supplemental immunization activities. But for us to be successful, we need to be able to track the cohort of kids that have missed their vaccination. So it's getting on 2.5 years now, or 2 years since the pandemic, and many of the kids have actually aged out of the standard immunization age group in many of the countries. So it might require, changing the policy or changing the training to ensure that those older kids who missed their vaccination earlier in the pandemic can be caught on. And we noted gaps in the literature that shows that few studies reported interventions or approaches. There's a lot of experience out there that needs to be captured. So this is really to encourage program officers, researchers in low and middle income countries to step up the documentation and reporting in the peer review literature so we can learn from this pandemic for the next one, which, as most people say, is going to happen. And then finally, in terms of preparing for the future, one thing that we noted was that there was a delay in bringing out guidelines and guiding the program officers in what to do to respond immediately. So programs need to be agile for when pandemics like this hit. And then there has to also be very clear communication to the public, right? To show them that services are still being offered and the safety measures that have been put in place to ensure that services are safe. And then innovations, should be evaluated and should be reported. So with that, I would like to say thank you to the team here, and we have here the studies that were included. Thank you very much.
I think that just those broad overviews of where we are in the pandemic really helps, us reflect on what has happened and so many shared experiences on the globe. But also just to think about how we can maybe react faster, and particularly, with protecting the healthcare workers at the front lines that have to do that work. So wrapping up this evening will be Dr. Daniel Ali, also from Johns Hopkins, who spent much of his career working in WHO in Abuja, and working also in new vaccine introductions with EPI, also the COVID-19 vaccine, also working on the Momentum project as well. So Dr. Ali, please, the podium is all yours. This one? Yes.
Yeah, thank you so much, Mr. Chair, and good evening, everybody. So my job this evening is just to take us through the challenges and opportunities routine immunization face in the era of COVID-19 vaccine rollout in Nigeria. So this is the outline. Look at have a context to the program, trend of immunization, performance in Nigeria, the challenges for routine immunization, and what the opportunities are in the era of COVID-19 vaccination, and then we conclude. This is just to set the stage for the presentation to say that routine immunization was declared as an emergency in the year 2017, resulting from the poor routine immunization coverage of mixed NICS of 2016. So this led to the establishment of the National Immunization Routine Immunization Coordination Center, abbreviated as NERIC, which focus on 18 priority states that are very high risk and high risk. And then 2020, the COVID came, disrupted activities, and in 2011, and 2021 rather, there were this geared effort to stop the pandemic, and one of the tools that was used was the COVID-19 vaccination. Strategic groups were set up, technical working groups were set up to coordinate the COVID-19 vaccination in the country. From the time of vaccine rollout till date, there have been several strategies, and we had the scale strategy 2.0 and now 3.0, all in trying to re-strategize to make sure that they ramp up COVID-19 vaccination and also integrating with PHC. We have the ongoing CVDBV outbreak, in the country, and so they are responding to that. This is just the Penta-3 coverage, the trend from 2015 to 2021. There has been an increase in the coverage from 2015 to 2016, but it plateaued in a way. So, and then 2020, we did not see any decline from the UNIC, but the admin data showed a decline from 2019 in 2020, and further decline also in 2021. So, suggesting also some effect of the COVID vaccination, or COVID and impact. This is just an overview of the strategies of COVID rollout strategies in the country. Since March 2021 till date, we had 3 phases of in the rollout, and several re-strategizing, all in an attempt to reach the eligible client with COVID-19 vaccine, set up 70% target, and all. The program has received strong political will at national level. Leadership from the MPACD was also there, and there were almost like a daily vaccination for COVID, and pulling out everybody from other programs. So this is just to tell you the commitment, the drive, and to make sure that people were vaccinated with COVID-19, and of course other programs will also suffer from that. There were challenges in all of this, and then from the planning and coordination, we could also see that because of the COVID rollout, so many demands, a lot of activities, some planned activities for routine immunization could not happen, coordination planning meeting, because there are so many priority activities apart from COVID-19. We have the non-polio SIAs, and we also have the polio campaign also, that also demand, request requiring attention so that we can also meet set target. Human resource for health also already, they are not adequate, but now increased workload also had that effect on them. And this led to the recruitment of volunteers to do some of the non-polio SIAs or polio campaigns, and also COVID-19 vaccination rollout. In that attempt, some of them were really not skilled. Service delivery, we also plan routine outreaches were not being conducted because of the demand on them for COVID-19 vaccination. And then there's this introduction of the performance-based incentives that made them to shift more to COVID because that will give them more money, and then kind of neglecting their primary role. For vaccines and logistics, because of the huge vaccine volume of vaccines in the country, there were not adequate manpower to really handle those vaccines, and so that led to the delay in the vaccine distributions, getting to the last mile. COVID vaccination provide funds for distribution of vaccine down to the district level, but there was nothing to push down to the facilities, and so individuals money out of their pocket to really get vaccine to the facility. Because of the integration process going on, there's a need for more vaccine carriers so that you can deliver both COVID-19 and routine vaccine. But there were a shortage of vaccine carriers, so that hindered co-administration of these vaccines at the vaccination post fixed site. For advocacy, some integration going on with COVID and RI, but the messages are more for COVID than routine immunization. Supervision, a lot of supervision for COVID, but that was now affected the supervision for routine immunization. And then there were a lot of checklists to be filled by supervisors that go to the field. That was also that added to the volume of work. For monitoring, because of the ad hoc staff recruited by COVID, and there's a need to co-administer COVID, same vaccination site with routine, there were issues of data entry errors because of capacity, because of volume, and so that affected the quality of data for routine immunization. There are opportunities that present. COVID came with resources, both human and material, that RI can leverage on already. The integration had started. And for monitoring data management, there is a dashboard for COVID-19 that is really the policymakers get to know about it, and then it also set competition between policymakers. So if we can also, routine immunization can live right on that and present those data, I think that also can help routine immunization. The EMID platform, which is the electronic management of immunization data, COVID brought it, and so it's an opportunity for routine immunization data also to be reported on that platform, which also helps accountability, also reduce, improve data quality. We have the call center for COVID-19 as well, to follow up on things for COVID-19 vaccination. That also an opportunity for routine immunization, also to use to follow up on some of the routine immunization activities in the field. Supervision integration will continue. There's a need to modify the TORs and also the SOPs so that the workload will be less as they integrate during supervision. Service delivery, every vaccination site post for SIAs and COVID should be used to deliver routine immunization antigens as well. Coordination, all coordination platform for COVID and non-polio SIAs can also be used to discuss routine immunization activities. There's a slogan in the country now: one country, one team, one plan, one budget, all to encourage integration, having one common plan, and then pulling resources together. The RI messages, opportunities with COVID-19 messages, there should be more of routine immunization messages on the COVID-19 flyers or any IEC material that is being used. Logistics, the logistics movement for COVID-19 should also be leveraged by RI so that all routine antigens can go together with COVID down to the last mile. And then training, every training, we should have RI modules in every training for COVID-19 and non-polio SIs. There are anticipated risks, but however, the country came up with mitigation plans. The bureaucracies of approvals at national and subnational needs to be addressed so that approvals can come for implementation to go on. Funds should be released on time. Health workers and beneficiary resistance to integration, they need to be educated, enlightened. For beneficiaries during health talk, for health workers during training, so that they will see the need for integration. And then the overworking of staff because of the demand in the face of shortage of manpower should also be addressed by increasing the HRH or straggling of activities or engaging retired workers or those who have just finished from school and are qualified. Disruption of programs and then change in donors' commitment, and that will create change in donors' commitment and program deliverables. They need to plan ahead and then engage those stakeholders in good time. Inequitable availability of funds in the drive to deliver PHC services. There is a need to have basket funding, pool all those resources for all the PHC services, and that way we'll be able to achieve the integration. So in conclusion, COVID-19 polio outbreak response, non-polio SIs have really added some additional demand on the EPI managers and service providers. MPA-CDA with partners have mapped out strategies for integration to ensure services are delivered seamlessly. However, this can only be achieved if the planned mitigations and the mitigation plans against anticipated risks for integration are carried out as planned. Thank you very much.
I think this session was just great from my perspective. I'm a clinical researcher, and to see some of the challenges at the end use and how do you fit in clinical research, and then ultimately with a new vaccine and how it's implemented. So I just want to thank all of the speakers. You're very busy. We hear about healthcare worker fatigue, some of the budgetary issues. We want to just thank you for taking the time out to share those experiences. We all learned from that. I think we have time. It's a little, because we had, I think, 7 speakers. It's a little bit hard, and we're a cozy group here. But if there are any burning questions that people would like to ask before we ask Irene Koek to wrap things up. Yes.
We are such a cozy group. Maybe I will manage even without the microphone. But sadly, the people on the street will be able to.
So cozy.
Okay. My jet lag is okay, but I will try. My name is Lukas Muraida, and I'm from Berlin, Germany. First of all, I also want to thank you for very nice presentations, even though I'm falling asleep, but not because it's not interesting, but I just cannot cope. We have the same problems. We are tired. I'm a central district in the city of Berlin. I'm the director of the local public health department. We are tired, we don't have money, we are losing everything politically. The pandemic is over and we'll not be able to continue many nice ideas because the pandemic had also positive effects on our work. I have had more people, more money, more opportunities. I have 3 comments / questions. One thing, the sustainability. Do you think you will be able to continue like this? Because my lesson identified is that there are many good things that we started, but we will not be able to continue like that. And I'm not sure whether it's really good. I think I have to reduce the offer or the effort that we make in order to keep it sustainable. So maybe it's not the special projects and the special efforts, but strengthening your public health structure at the local level. What do you think about that? The second small comment and question is the capacity. How many, most of all, the Kenya, but actually it's for all. How many of the people do you reach? Is it not too much capacity consuming? I mean, we do the same thing more or less, but it's very costly. So how do you prioritize, and how many of the people you really reach? Are you able to cover all of them with this? Because it's really like you really visit everyone, so it makes sense, but is it the real approach? And then my biggest interest, how do you keep the records? How do you make sure that those people, if they lose their confirmation of immunization or whatever, or if they travel, or if they need to flee, will they have any record of the immunization? So how do you organize that? Do you have a digital system, or do you keep the records at the public health offices, or how do you manage that? Thank you.
So maybe I could suggest, since we could probably hold another symposium of 2 hours to address all of that, but maybe we'll pass the mic to our colleagues from Kenya, maybe to just address, how do you feel about the next year in terms of sustainability and continuing on?
Thank you very much for the questions. So for sustainability, the incorporation of the strategy by the national team actually is one way of actually having it as a sustainable way. And we've actually even incorporated it at the facility level. So when we do our micro plan, part of what we are going to do is to ensure that we have it as part of the strategy for that particular link facility, to ensure all the people within that village that it's serving are actually captured. So we looked, whenever we have any program that we do, one of the things we look at is how sustainable is it? Can we incorporate it in the system? So we've have that issues of sustainability addressed because of the national level adopting it, and also the facility level actually having it as part of their micro plan for immunization to meet their target for immunization. The second question was about capacity. So we do have, currently we do have something called moonlighting in walkways. So what we do, we have part of our teams, because yes, the issue comes in once there's issues of resources that are there. So to address that particular issue, we have some of our staff now sort of takes off and come in to go serve the community. So we, like for the moonlight, we actually have staff who are stationed in a static post in areas where we have high level of movement to actually ensure they capture the client once they pass there. Or we have areas where we know in a marketplace where we'll have a lot of mothers coming in to shop or to sell. We have our team now stationed. And those particular teams will be off duty, so they become, it's like their normal work day for them to go in that area, so that we don't, and we found out we tend to reach, because each link facility has a specific target to meet. So you tend to reach a lot of people within that particular village that we're serving.
How much do you reach from the 100%?
So if I look at what we had a drop, so in May 2020 to about, in February to May 2020, we had a drop of about 56%. So by June, once we realized, and we started the door-to-door strategy in May actually, May is where we start, and we found we got more than what we had target. So like for instance, if you can still remember the bar graph that I was showing, we had a target of the defaulter that we have picked are like 41, but when you go on the ground, we find we get more than what were not in the list. So we're almost about 87 to 90% of the clients within the area are reached. I remember the other question was, how do we know that the records? So we do have our MOH tools that we capture all the data, all the children that access the facilities. Yes, we do have an online. We have KHIS that has an online. But at the facility level, we have the tools that we record all the kids who are coming in. And through that tools, we can actually check who has come in for the appointment, who have missed the appointment, and we can have them as a list. For the parents as well, we do have a booklet that's called Mother to Child booklet that actually stay with the child for 5 years. So the mother pick it when they're pregnant and go all the way to 5 years. And that's the booklet that they have to show that they were vaccinated, not vaccinated, this was given, this was not given. And wherever they go in Kenya, they can still produce that book and get services using that book. I'll ask Linda to answer.
Yeah, and just a little, just an addition on the sustainability part. Since this has been incorporated into the national guidelines, that means we, as a country, we've added, when counties are actually developing their county integrated development plans, they're able to budget for this strategy in their CIDP, the county integrated development plan. So meaning if they're able to budget for it, it means there's actually funding to be able to support this strategy. So that's one of the advantages or a low-hanging fruit that if it's been put into the strategy, the counties are able to allocate a budget for it. Thank you.
Great. Thank you so much for that. Clearly there's enough information and fodder to have a whole nother session, which we're not going to do tonight because it's late. But clearly, and I think maybe our next year we'll need to have a full-on discussion session so we can have exactly these kind of exchanges. And what was also striking to me is how much consistency, if you will, and exactly as we saw in the literature review, there was literally around the world of what the impact of COVID was on vaccination. So my job now is to close us out. I first want to thank all of you for joining us here tonight and for listening to these really, really, really interesting sessions and presentations. I want to thank our tremendous panelists who just brought, not only for the work you do every day, but sharing all of that incredible work and your thinking, your analysis, and all of your data with us. It was really just fascinating to listen to the different approaches. Each one has been tried in so many different places, and we really, really appreciate that. And thank you so much for sharing that. Really want to thank Chuck for being a phenomenal moderator and keeping us pretty much on time. We are right on time, so thank you so much, and for hearing all of us. And last but certainly not least, I want to thank my colleague, Dr. Rashid Shah, who was the instigator for this panel, who brought everybody together. It was his idea and his convincing all of these tremendous panelists to join us today. So thank you so much, Rashid. Thank you all, and good night.